Okay, so we're going to talk next about assessing wounds and then about the principles of wound management. We want to assess wounds by color, okay? And we have a simple way of looking at the color of the wound. If wounds are red, if the base of the wound is red, that's healthy tissue, okay? We want to encourage healing. If the base of the wound is yellow, that can be purulent drainage, in which case we have infection, or that can be slough when a bunch of fibrin and gets deposited in that wound. Slough is going to interfere with healing, and so we need to remove the slough for the wound to heal well. And if a wound is black, that means it is either ischemic or necrotic, okay? Now, we may also have, sometimes that slough and other gunk sitting in the base of the wound hardens into this thick black crust, and that's called eschar. But either way, black wound is eschar or dead tissue. And so that has to be debrided. We assess whether the wound is opened or closed. If the wound is open or closed. If the wound is open, it's at greater risk for infection. So we're looking at how at the depth of that wound maybe, and at whether that wound is clean or dirty. We also assess if the wound is closed, we want to know how it's closed and is it well approximated. So is a wound closed? Is it just a well approximated simple cut? Okay, or is it a wound that's been closed with sutures or staples or steri-strips or some dermabond, something like that? What is it closed with? And how does that incision look, or how does that wound look under beneath that closure? So are the edges well approximated? We want to look at size and shape of the wound. We're going to measure the length and width. We're also going to describe the shape of the wound. Is it round? Is it ovoid? Is it linear? We're going to measure the depth of the wound and make sure that you're measuring, that you're looking for any tunneling, especially really deep wounds can tunnel. We can have tissue that's been damaged that causes that wound to tunnel. And we assess for edema around that wound. We assess the drainage from a wound. So we want to look, is that what kind of drainage do we have? So there are different types of drainage. Serous is clear to yellow straw colored liquid, and it's basically just tissue fluid and maybe serum from the blood. So that clear yellowish drainage. Sanguineous is bloody, okay? If it's combination, if it's like clear fluid with blood in it, it's serosanguineous. Purulent is drainage that has pus. It is, it can be yellow, green, brown, different colors, but if the wound has pus, it has purulent drainage. Purosanguineous is pus and blood mixed. So we want to look at what type of drainage is there. Now, if a wound extends into any type body cavities that might produce a different kind of fluid, we may actually have different kind of drainage in that wound. But those are the basic types of drainage from the wound itself. We also want to document, are there drains or tubes? And if there are, what kind of output do they have? So do they have an abdominal incision with a JP drain? Or do they have a Penrose drain out of that? What kind of drains or tubes are there, and what's coming out of those, and the amount, what amount of fluid is coming out of those drains? And we also want to assess whether wounds are painful. More severe wounds, deeper wounds, wounds that have damaged the nerves actually tend to be less painful than shallower wounds. That's not always the case. Sometimes you do have patients with deep wounds with a lot of pain. But wounds, severe wounds that are painless, indicate that the nerves have been damaged. There are some general principles of wound management. First of all, we want to keep that patient, or we want to maximize that patient's health status to promote healing. We want to make sure they're getting adequate fluids, because if we have enough fluids, we have enough blood volume, then we can carry the things that are needed for healing to that body tissue that needs healed. We want to make sure they're getting enough calories. If they're in a calorie deficit, they're actually going to break down their body tissues instead of rebuild them. Protein in particular, we want to make sure they're getting adequate protein. Low serum albumin indicates that they're getting inadequate protein in their diet. Someone with a severe wound needs extra protein. And we're going to supplement vitamins as needed. Now, because remember, some of those vitamins are important in healing. Vitamin C, vitamin E, zinc, there's several others, but some of the vitamins are important in healing. We also want to look at vitamins that are important in formation of white blood cells. Okay, so if a wound is red, meaning it has a nice, healthy red wound base, then we want to protect that wound base and allow it to heal. So that wound should be covered. The dressing should be changed infrequently, but we want to keep it covered so that it stays clean. And we don't want to disturb the wound bed. If you have a wound that has a nice red, healthy base and you do a wet to dry dressing on that, when you pull that wet to dry dressing out, you're actually pulling out healthy tissue and making that wound worse. So red wounds are healthy. We want to cover them. Don't disturb the wound bed, keep them clean, allow them to heal. Yellow wounds need to be cleaned or debrided. If it is pus, that needs to be cleaned out. And if it's slough, that needs to be cleaned out. And that doesn't mean we get really, really vigorous and we dig in and rip that out and disturb all the healthy healing tissue. There is a place for vigorous debridement in some wound care, but most of the time with our dressing changes, that's not our goal. So we need to clean and debride yellow wounds. And so that may be done. We want something maybe to absorb the exudate. We probably are not going to do wet to dry dressings. Okay, let me rephrase that. A lot of doctors are still ordering wet to dry dressings. They are not recommended for wounds generally. A wet to damp dressing is a safer way to debride. So when you do a wet to dry dressing, you put wet gauze inside the wound and then cover it with dry gauze. So the dry gauze wicks the water out of the wet gauze, and then the wet gauze dries out, sticks to the wound. When you remove it, it pulls out some of the debris that we're trying to get rid of. But when we do wet to dry, it also pulls out a lot of healthy tissue with it. So wet to damp just decreases the amount of debridement, but it also saves some of the more of the healthy tissue. So wet to damp dressings may be used for debridement. There are specific dressings that promote our body's own enzymes that break down that slough, that thick gray yellow stuff that gets in the bottom of wounds. If a wound is infected, antibiotics are needed. It's not going to heal until until the infection is cleared. So yellow wounds, clean and debride, treat the infection. Black wounds need to be debrided. They may need to be debrided by sharp debridement. That eschar or dead tissue may have to be removed surgically. There are some other specialized types of dressings that may do that, but black wounds need to be debrided. When we are cleaning a wound, we need to clean from the least contaminated to the most contaminated part of the wound. And if we're going from, we have several wounds, we want to start with the least contaminated wound and finish with the most contaminated. You want to use gentle friction, don't scrub hard, because you want to avoid damaging healthy tissue. That healthy granulation tissue that begins before we start actually making new skin is very fragile. Isotonic solutions are preferred. So sterile saline is one of the most common. There also are some wound cleansing solutions that are isotonic, but those are preferred. Gauze should be used only once, so we don't go back and forth, back and forth. You do one swipe, drop, one swipe, drop, because we don't want to carry bacteria from one part of the wound to another. Avoid materials that shed fibers. So when you're cleaning if we use 4x4s, if they're not cut, those don't tend to shed fibers. If we're cleaning with cotton balls, that's going to leave fibers in the wound that can actually become a focus for infection. If we're irrigating a wound, we want to use a large syringe with a small needle or catheter, and that can increase the pressure so that we can irrigate the room. If you irrigate, it is better to use an IV catheter with the needle removed. If you use an actual needle for irrigation, there's always the risk of either the patient moving or you moving and poking the needle into the patient. So use a catheter instead. There are specialized syringes and catheters for wound irrigation. If you don't have those, you can put you can put just an 18 gauge IV catheter on the end of a 20 cc syringe and use that. Pain management. If your patient has painful or difficult dressing changes, please pre-medicate them before that to make it less traumatizing for the patient. You want to prevent and manage infection, so use the infection control information that you know. You don't want to contaminate wounds. If you go in and the patient needs to be cleaned up, do that. Then wash your hands, new gloves. Some wound care is sterile. Some wound care we use sterile technique. More often, currently, we use clean technique, but make sure that you are using clean technique. Change your gloves after you've removed that old dressing, put on new gloves to do the new dressing, things like that. Different dressing types. Gauzes are used just to absorb the exudate. So a gauze sponge might be used if we have a wound with a lot of exudate, just to absorb it. Non-adherent dressings are dressings that are intended not to stick to the wounded tissue, so that it doesn't pull off healthy tissue when you remove it. So that's something like Telfa. A damp to damp dressing is used to debride. We talked about damp to damp dressings. You pack a wound with damp gauze, cover it with damp gauze, and then you're going to cover it with something dry and wrap it. Self-adhesive transparent dressings like Tegaderm, those are temporary cover for small superficial wounds. I've seen those used on larger skin tears, and you've got to be careful. You'll end up with infection under that. But Tegaderm can be helpful for small wounds. Hydrocolloid dressings like Duoderm seal in moisture, and they support the granulating wound bed. So this is a really good one for deeper wounds that are stage or for larger wounds that are red, they have a lot of granulation tissue. So that Duoderm seals in the moisture and it supports that wound bed. They can stay in place up to 7 days. We also sometimes use these on stage 2, those shallow, but maybe it's got a bigger surface area, or those stage 2 wounds over a bony prominence, because the Duoderm also provides some padding. Hydrogel dressings are mostly water. They promote autolytic debridement, so they promote the enzymes that actually help break down that fibrin that makes up the yellow slough stuff. They fill the dead space. They can be used to help debride infected or necrotic wounds. They also keep the wound bed moist, and they can stay in place for up to 3 days. So a lot of us were probably told to let wounds dry out so that heal. Keeping wound beds moist actually promotes healing. Wound vacs. Some of you have probably used wound vacs. This is called vacuum assisted closure. The wound is filled with a special sponge or foam material, and the wound needs to be filled completely, but that foam doesn't need to be on any intact skin. So the foam has to be cut to fill in the wound, and then negative pressure is applied. So for negative pressure to work, you have to get a seal. So that wound vac sponge is cut to fit the wound, and then it's sealed down with something similar to Tegaderm. And negative pressure is applied. That speeds tissue regeneration, it decreases swelling, and it maintains a moist wound bed. So they've been shown to improve healing. Anytime you do wound care, you document the status of the wound with measurements, and you document the care provided. In a lot of facilities, that documentation is a photo of the wound, but it's really important that you describe the wound accurately, because if you're not the next person that changes that dressing, the next person needs to be able to determine, is this wound getting better or worse? Okay, in the next section, we're going to talk about some wound complications.